Hi, everyone, and welcome to the AGD podcast series. I'm your host, Dr. Wes Blakesley. One of the paradigm shifts that's occurring in dentistry today is the evolution of a closer bond between medicine and dentistry. Sleep medicine, the oral systemic connection, and oral cancer research are just a few of the areas where our respective professions are sharing knowledge for the benefit of our mutual patients. But I would submit to you that the most exciting new technology that we can take to the operatory tomorrow morning is salivary diagnostic technology. To discuss this discipline with us today is Dr. Ron McGlennon, who is a physician and the medical director of Oral DNA Labs in Minnesota. So, Ron, good morning, and it's great to have you with us here today.
Good morning, Wes. It's a pleasure to have this opportunity.
Ron, you have a very interesting background in medicine. I'd like you just to share a little bit about that with us.
Well, I think it's fair to say that my mind is always centered around numbers and experiments, and so I'm kind of a scientist at heart, but my background is, first of all, medical school at the University of Minnesota, and then I matriculated into a residency program in laboratory medicine and pathology. So the background that led to me being a pathologist. But as one of my professors once said, if you want to waste your time on some of this new technology, go ahead and do so. And I did. I invested my next phase of education in molecular genetics. And so then I got boarded in molecular genetics. And so I was in that sort of the ground floor of using DNA and genetic testing technology in the clinical lab. I played that out for 15 years as a professor at the University of Minnesota, and then I got a little tired of seeing it only go to academic physicians, and so I set out to start a company called Axis Genetics, which had as its mission to make this technology available to everyday pathologists across the country. And through time and through evolution, we acquired a specific interest, which now is focused on oral salivary diagnostics, which to a great extent serves the dental profession.
And thank God for that. Ron, your lab, Oral DNA Labs, is nearly 8 years old right now. How would you describe its mission?
Its mission originally was the idea from a group of entrepreneurs, and including Dr. Tom Neighbors, a practicing dentist in the Brentwood, Tennessee area, and he's really a luminary in the idea that the clinical laboratory can provide a lot of new information to the practicing dentist that solidifies diagnoses and creates information that can prognose. So I got involved as an adjunct to this, first as a medical director and as a purveyor of some of this new technology to set up oral DNA labs. And through a series of business transactions, first passing through Quest Diagnostics, my company ended up acquiring Oral DNA Labs as a division. And its mission, simply put, is to bring all aspects of the clinical laboratory and its precepts and its behaviors and its insights to the practice of dentistry. Now, the path to get there involves using modern technology, and I'm going to make some comments about that through this podcast. But I come from the vantage of what can we do today with very sensitive molecular genetic technology, and that's where we start. We're not going back to old tissue diagnostics. It's not basic chemistry. It's molecular genetics first and foremost. So the dentists are being introduced to the clinical laboratory that high on the ladder where many physicians are still starting to climb that ladder.
Interesting. Ron, what is the scientific basis for the tests that are offered by the lab for patient care?
A couple things that are really critical to know about molecular genetics is that the sample we take from our mouth is reflective of all of the cells in our body. So the genetic signature that we get from the cells that we take from the epithelium in our mouth is a reflection of all the susceptibilities and resistances that we might have as persons. But also in the mouth is a host of other microbes and organisms And we've come to know now that the oral microbiome should be viewed as fundamentally vital to oral health as the gut microbiome is to gastrointestinal health. In fact, we talk now about bacteria as being that additional organ as central to our body's functioning. So the basis then is the use of DNA and RNA testing technology. It's fundamentally more sensitive, it's very, very specific, and it's very, very versatile. The convenience of collecting an oral rinse or a scrape sample from the inside of the mouth can be readily transported from office to laboratory without fear of it being degraded. And all the specifications that happen in hospital lab testing are sort of diminished. We have a robust solution to then apply to a bunch of different questions. Most of the questions we ask are about what is the relationship between bacteria, viruses, and fungi in the mouth and how they relate to the host response to that.
Okay. Ron, what role do you see the laboratory playing in the care of our patients, of dental patients?
Well, there's a couple aspects to this question, Wes, and I think it begins with the notion that all medicine today should be viewed as multidisciplinary. And so your introduction alluded to the fact that dentistry is part of the larger genre of medicine, and we should view it as such. And so any specialty in medicine has a reliance on radiology, the clinical laboratory, and other specialties to sort of put the puzzle together. So any patient coming to you with a complex disease deserves not only the sensitive approach towards a careful clinical exam, but the value that the clinical laboratory and other adjunctive services and specializations bring to bear. So what we believe is that we want to be that angel on the dentist's shoulder. We have a variety of tests, a portfolio of test offerings that can help make the diagnostic challenges easier. And I would add a couple of other points. I think it's fairly true that dentistry is a somewhat insular profession, and you learn what you learn in your dental school, you take it up in your practice, but the intercomparability between offices is sometimes leaves one wanting for, that comparison. The laboratory is a great bridge for that. It provides you with a piece of data which has nothing to do with what your eyes or hands have experienced, but what is going on at the molecular level or at the cellular level, and you can hold it up and show it to the patient, you can show it to your colleague, you can use it as a point of conversation and consultation, and so we're a bridge as well as we're a way to sort of make more vivid the colors of the whole clinical scenario.
Sure. The graphs that you provide are extremely educational for the patients. And, I think there's an old saying, the eye way is the highway to the mind. And it surely is in the case of the reports that we receive.
Well, thank you. We spend a lot of time poring over the concept of how wordy, how graphical. And I am very sort of matter-of-fact about the reality of the laboratory test clinician interaction. It lasts about 1 second. You hold a sheet of paper up to your eyes, you read it, you get the information you need, and then you move on to do what you're going to do. And that's where the focus is. But if you read further into our report, there are serious considerations about therapeutic approaches, references, and in some cases now some more nuanced interpretive information, which might then also give you language when you're talking to your patients and explaining these results.
And they enjoy it. The average person today is, they're on the computer, they read, there's things in the media about health and dentistry, and they really enjoy it. So I can tell you as a user, it's very well received. Ron, I'd like to get into some of the specific tests that you offer, how they're applied to patient care. It's a two-part question. And then, what patients are candidates for salivary testing? Is it every patient? Do we select a certain grouping or subset of patients for testing? So who are candidates for this?
Well, I think I can answer the latter part of your question firstly by saying that when I go to my internist and I have a complaint, probably the first thing that is going to happen is some sort of a laboratory test is performed or requested. And that becomes kind of the guidepost as to how the ensuing conversation goes. So whether you're talking about a patient who comes to you who looks really healthy or a patient who has very considerable disease, there is a laboratory solution to help exalt and examine that situation. So let's talk about a couple of these tests. Probably the premier example of what we do every day in our laboratory is to look at a profile of known bacterial pathogens which are known to be causative of periodontitis. Now, heretofore, I think periodontitis for most of your listeners is a clinical diagnosis. Swelling, bleeding, retraction of the gum line. And we certainly know that there are bacteria there, but you'd be surprised in the number of tests and the expanse of those results that we see, how diverse that bacterial signature is. So the test that we perform, which is called MyPeriopath, imparts the idea that, first of all, we're looking at pathogens. We're looking at them quantitatively in a spectrum of sort of good to medium to not so bad. And we look at them quantitatively. So we have a sense of how much and gives you a strike point so that when you apply treatment and you retest, you're going to see those bacterial levels go down. That's the goal. So where do we apply this? A test such as that, you might think, well, it will be helpful to a patient who is middle-aged, comes to me with garden variety chronic periodontitis, and you're correct. It helps you to identify what is the compilation of bacteria causing that person's disease. And I'm here to tell you that that compilation of bacteria differs between family members and across ethnicities and varies considerably over the age range. And then you're going to use that information to select your therapy, apply it, have them come back 6, 8, 10, 12 weeks later, and then you're going to test them again. Was your therapy successful? Let me give you an example where, the obvious, I did a good scaling and root planing, I applied systemic antibiotics, you would expect all that to turn out very well. You come back and see them again, and now their mouth seems to be in much better shape. But you find out that there are a few bacteria which are persistent. What would you think that to be? Well, first of all, there are bacteria which respond to different therapies differentially. Second, in this day and age of antibiotic resistance, we have to be ever vigilant that we are finding patients who are reservoirs for antibiotic resistance, and that's going to change the next time you apply therapy. But then let's talk about the other end. We're talking about a young person who comes to us, and they're not quite as attentive to their health, and you're finding that their dietary, their exercise level, and so on is setting them on a course, but they don't have evidence of periodontal disease. Do you think that their periodontal biosignature would be abnormal? The answer is emphatically yes, and we're finding evidence of very significant levels of red complex bacteria occurring in people in their second decade of life, right out of adolescence. And as we like to say here, why would you let that patient get into the churn? They're on an inevitable course towards higher levels and worsening infections and hence worsening gum disease. You could find that out early. So you can apply this test to young people as well. Let's talk about some other things that we do. The mouth is a reservoir for other types of infections, and one particular area of expertise that I have is in the area of human papillomavirus. I knew this 25 years ago, but it took until the mid-2000s here for us to acknowledge that HPV causes the majority of oral cancers, 70 to 75%. It's no longer the old person smoking, drinking disease of the 40s, 50s, and 60s, but now it's a disease of younger men and women who are unsuspecting to their risk, who harbor an HPV infection that has gone badly, And so you have an opportunity to not only find it very sensitively, even before an obvious lesion occurs, but you also can use these tests to talk to people, even adolescents, who are at risk by virtue of their sexual behaviors and other types of activities that would put them on a course for the potential of oral cancer. We have other things in mind, too, and we're looking at tests for dental caries. We look at other infectious processes. And one of the things that I think has turned out to be really useful is the advent of really simple tests like characterizing the Candida infections that dentists often see. You look in the mouth, you see a lesion, you see an ulcerating lesion, and you ask the question, is it herpes, is it Candida, or is it actinomyces or whatever? Well, you don't really know, and to a great extent, you're going to treat them sort of generically. But wouldn't you like to know that about 25% of the time it's not Candida albicans, that in fact it's Candida glabrata, which actually is a reservoir for antibiotic resistance? You can save yourself time and so much more challenges to the care of your patients if you know diagnostically precise information. So that's a spectrum of what we do. Last, I just want to comment, we also provide testing on the human genome. To be very clear, periodontitis is a disease which actually is the inflammatory response to the bacteria. And so we have now genetic markers which can profile individuals' robustness of their inflammatory response. By knowing this information, you're going to better understand if that patient is going to be in your office frequently or less frequently based on how exuberant their immune response is. And we can do that now by looking at that same oral rinse and at the gene markers that come from the human cells that are part of the sample.
So that would be the MyPerio ID test?
It's called MyPerio ID, or a newer version of it, which is called Celsus One. I can explain the name if you wish. Is actually a next-generation sequencing panel of a host of gene markers, that some of which are up and some of which are down, and on balance we can compile a composite score that gives you a sort of a global sense of that immune or inflammatory response. You were referring to MyPerio ID, which is a test that looks specifically at interleukin-6. Celsus One is actually a panel that includes interleukin-1, interleukin-6, TNF-alpha, and others that escape my mind at the moment.
So you have basically, two tests then for a periodontal patient. You have the MyPeriopath, and then you have the Celsus One for genetic profile or background, correct?
That's correct, yes.
And then also a test for Candida and other fungi?
And other fungi, and we also look for chlamydia and Neisseria, and we also look for human papillomavirus. So we've got a spectrum that's really focused on infectious disease or response to infectious disease. And more to follow. But right now we're trying to get traction with these tests right now, and that's a lot.
Yeah. I just want to throw this out there. I have a patient. She's been in my care for 35 years. Healthy periodontally. She has chronic fatigue syndrome. I think a little history of fibromyalgia. And to make a long story very short, she came into the office. We talked as we always do. Told her about your lab and testing. Demanded a test. We did one. Off the scale for AA, for Gregobacter actinomyces, off the scale. And very surprising. So, now the challenge is you have a patient who has no pocketing, good tissue tone, but she's off the scale for a bad actor, a serious pathogen. And then, the question is, or begs the question, how do you manage these patients?
You manage disease locally, but you have to think very broadly. And so sort of my really quick response to a little bit of the clinical history you described gives me pause when I think about that high level of AA, which is not just present in the first time you tested her, but has been with her a long time. And that's creating an inflammatory burden. Okay? That inflammatory burden is played out in the mouth, but it's also played out systemically. And so is there evidence to suggest that that inflammatory burden contributes to some of these systemic manifestations of disease, whether it be fatigue or potentially some of the rheumatologic considerations that you put forth? I think the evidence is very clear that it is. Now, I'm not here to suggest that measuring AA in her mouth is diagnostic of fibromyalgia, but I think the evidence is strong that it is contributory to it. And so your job, in part, is to treat that. And you might, with hope, see her systemic systems rebate. I don't know. Things can be very complicated, but you should at least take that into consideration.
I think in a conversation that I had with you and Dr. Nagelberg that there was some research being done correlating juvenile RA with some oral pathogens. Can you comment on that?
We are just now embarking on a study which attempts to identify patients who have juvenile rheumatoid arthritis as compared to a control group who do not, and looking at their periodontal bacterial signatures. The hypothesis is that some bacteria will be elevated and that there will be an increased inflammatory burden. Now, there's no question that a disease as complex as juvenile rheumatoid arthritis probably has a innate or inherited genetic susceptibility, which then leads to some, if you will, and I'm speaking crudely here, confusion of the immune system. But the stimulation of that confused immune system by this inflammatory burden caused by periodontal pathogens might tip that patient into now generating those autoantibodies and hence developing this very debilitating disease. That's the theory. This will be a pilot study that we're doing, and then subsequent to that, that data will be put forth into a longer-term prospective clinical trial. So another comment is that Oral DNA Labs is very enthusiastically involved in a broad spectrum of clinical research. We're using our clinical laboratory and our specific expertise in testing things in or about the mouth to help investigators touch on a number of topics. The role of periodontal pathogens in pancreatic cancer, the role of periodontal pathogens in Alzheimer's or dementias, the role of periodontal pathogens in inflammation in these rheumatologic disorders. And then most recently now, we're sitting at the table to design and outline and implement studies that are looking at the periodontal pathogen and cardiovascular disease association. That is very strongly aligned. We've moved that dialogue from the word association to causality, and this is a fundamental shift in our thinking. Now, we now believe that along with abnormal lipids, periodontal pathogens are causative of atherosclerotic heart disease. The dentist will play a key role in mitigating that disease in the future.
Interesting. Also want to make a comment here, and again, I have no association with your lab, so I'm just an interviewer here, but you have a very excellent Facebook page, and our mutual friend and colleague Dr. Nagelberg, writes some nice pieces on that. I would encourage anyone listening in to this podcast to go on the Facebook page for Oral DNA Labs and take a peek at what Dr. Rich Nagelberg writes. It's very incisive and illuminating, and we need this knowledge as practicing clinicians. He does a very nice job. Ron, just to kind of drill down here and break it down. So I'm a new dentist. I'm listening to this podcast. I'm out in Nebraska. I want to do this. This is really neat technology. So how does it start? I make a phone call or contact the lab, and then what's the next step? What happens?
You can go to our website, oraldna.com, or I can give you the telephone number, 1-800-ORAL-DNA, and you'll be able to reach our customer service group. We don't have in the field sales representatives. We have found to be very successful just developing a very interpersonal and interprofessional relationship. Our customer service team is crackerjack at saying, we just need a couple pieces of information. We'll send you some collection kits, And then the follow-on with our dental hygienist support team will instruct your staff as to that first collection. FedEx picks up your samples. We use the web portal to submit the order in advance of the sample getting to the laboratory. Most, if not 99+% of our samples are an oral rinse, so the patient is instructed to take a volume of saline, swish and gargle for 30 seconds, and then expectorate back into the tube, slap the label on, stick it in FedEx. The result comes back through the web portal, and we're very proud to say this, in about 2 to 2.5 days. And that precise because for us, turnaround time is all about service. It's all about making sure that these laboratory results are back in the office in a time frame that makes them useful. That the next time you see that patient or pick up the phone call and have the follow-on visit, you have that data in hand. So that's how the process works. Customer service sets you up online, takes about 10 minutes, and you're up and running. And then I want to just add one other thing. I started out by talking a little about the mission of our laboratory, and indeed, it's about samples and tests and taking the advice of how we can expand that menu of test offerings that best suit the dental professional needs. But it's all about consultation. We understand that this is a new concept in dentistry, to have the laboratory be a routine member of the team. And so whether you're talking to our hygienist, Kim, or Diane, you have an equal likelihood of reaching me. And I'll give it to you straight. I'll give you a consultation. I'll tell you where to take the laboratory results. I'll tell you where you can get additional information and help you weave that specialty of lab medicine into your practice.
It's seamless. We've been a user for several years, and I can tell anyone listening in, it's a seamless process and very easy and very appreciated by the patients. That's been our experience. Ron, we're almost out of time, but I'd like to ask you, what are some of the new directions of the lab? Where are you folks going? What are you thinking about, and what's on the design table for the future?
Sure. Basically 3 areas. First, I don't think that we should be limited in our thinking about what group or spectrum of diagnoses dentists are privy to. You sit at the feet or in the presence of patients who are more likely to see you than to see their physician. So hence, the extent to which we can use laboratory to gain insights about what's going on in the mouth and elsewhere is completely in our crosshairs for the future. Firstly, that involves expanding the spectrum of infectious diseases. And so one of the strategies in embracing that is let's use conventional cytology, cells collected from that oral rinse, to guide us as to which molecular tests need to be done downstream. Cells tell us whether there are bacteria, fungi, or viruses involved, and then we use the DNA and RNA from that sample to better delineate what are the specific causes. So we're going to use cytology to beget where we're going with these infectious markers. Second, I want to talk about some of the things that are big trends, but which dentists fundamentally need to be good citizens about, and that is antibiotic stewardship. And so in the very near term here, we're going to be talking about surveilling patients and diagnosing patients who demonstrate antibiotic resistance. About 40% of the world's antibiotic use comes out of the dental office. Well, in this day and age, that is a harbinger from everything in that patient's health spectrum. People are going to die in the future if we're not good about antibiotic stewardship. We want to be a laboratory that embraces it first. Thirdly, there's a host of things we can learn from human genetics. And so I talked about Celsus-1 as looking at the profile of a patient's inflammatory spectrum or response. But we can drill down on human genetics to look at gene markers that look for early or inherited forms of periodontal or dental caries. We can look at other diagnostic tests, and let me leave you with this provocative example. in as much as patients trust their dentist more than they trust their physicians. You can also give that patient an interesting set of results in the area of pharmacogenomics. Today we offer a test called DNA Drug Map. From that same oral rinse sample, we can look at how patients will respond to medications, which ones to avoid, and that piece of data goes with the patient. It might dictate whether you use a narcotic pain reliever when you do an extraction or a molar extraction, but that information goes to their OBGYN or their family practitioner as it applies to their antihypertensive medication and so on. DNA Drug Map is a pharmacogenomic profile for that patient, and what better place to do it than in the sort of the comfort of that dentist-patient relationship.
And that exists today?
It exists today, yes.
Excellent. Excuse me, Ron. Thank you first for devoting your time to this interview. Believe me, I know how busy you are, and I really appreciate your making time for this interview today. A very fascinating and robust discussion, but I knew that was coming, so I'm not surprised by that. But I did enjoy it, and I thank you for being here. Again, for the members listening in who want to contact Oral DNA Labs, maybe you could just repeat your contact information before we close off the interview.
You can contact us at 1-800-ORAL-DNA or at oraldna.com, and there'll be a link there to our support team, and that'll get you to our customer service and indirectly to me, and I'm always available. So don't be afraid to reach out. I'll talk to you at any time, morning, noon, or night.
Thank you for that, Ron, and again, thanks for spending some time with us today.
Thank you, Wes, for this opportunity.
Take
Have
care.
a nice day. Bye-bye.